Now I will move on to another important trial, the DIGIT-HF trial. Now I will give you a background regarding Digitalis in heart failure. In the major DIG trial published in 1997 New England Journal of Medicine, a landmark trial that you need to know, that trial took patients with heart failure and sinus rhythm. And they took mainly heart failure with reduced EF, but they also had a subgroup of EF over 45%. And in those patients, the addition of digoxin to standard therapy of the time reduced pump failure death, but was offset by an increase in arrhythmic death, making digoxin neutral on mortality. However, digoxin was overall beneficial and reduced heart failure hospitalization by about 25 to 30%, particularly in the more severe cases, the lowest EF or the classes 3 or 4. In fact, there was a benefit on heart failure hospitalization even in the group of EF more than 45%. Now, a key idea that came out of that trial is the importance of digoxin levels. The median dose used in that trial was 0.25 milligram of digoxin. And post hoc analysis of that trial showed that digoxin levels of 0.5 to 0.8 were associated with a lower mortality than placebo, overall mortality, whereas levels more than 1.1 were associated with a higher mortality than placebo. In addition, another study, a dosing study, showed that all of the hemodynamic EF improvement and autonomic improvement with digoxin, including rate control and sinus and AV slowing, is seen at the lower dose, 0.125 milligram per day, and lower DIG concentration without further improvement at higher doses. So overall, the takeaway from this trial is that digoxin is beneficial on heart failure hospitalization, particularly in the most severe heart failure, and may even be beneficial on mortality if you use lower doses with the proper digoxin level monitoring. And that's what I've been doing when I use DIG, whether for heart failure or I use it for AFib, even though that trial was not a specific AFib trial. But anyway, I use digoxin, then I check levels 1 to 2 weeks later. Then I keep checking levels routinely every couple of months, as well as with any change in medical condition or kidney injury or any hospitalization. Now, digoxin got forgotten in the current era of 4 pillars of heart failure therapy. Now, here comes the modern DIGIT-HF trial of patients with advanced heart failure with reduced EF treated with modern therapy. And it showed that low-dose digitoxin, not digoxin, slightly different, I'll explain. Low-dose digitoxin with monitored levels significantly reduced heart failure hospitalization by 1.7% per year and showed a trend toward mortality reduction by 1.1% per year. And the most important idea is that this benefit was seen even on top of modern heart failure therapy. The overwhelming majority of patients were on beta blocker, ACE, ARB, ARNI, and MRA. SGLT2 inhibitor was only 19%, partly because the data of SGLT2 came out while the trial was already getting conducted. But the overwhelming majority were on 3 drugs and many were on 4 drugs. And this trial specifically enrolled sick patients with heart failure, the majority of whom had NYHA class 3 or 4 despite that modern therapy, or NYHA class 2 but with an EF less than 30%. The GFR was 65 plus or minus 23, so there was some CKD here. And importantly, unlike DIG trial, 27% of patients had AFib, and the benefit was seen irrespective of the rhythm, whether sinus rhythm or AFib. So we know now that patients with AFib and heart failure do derive benefit from Digitalis based on that trial. Overall, this data revives the value of Digitalis in patients with advanced heart failure despite the 4 pillars, or those intolerant to the 4 pillars. For example, many of those patients with advanced heart failure may not tolerate the 4 pillars or may not tolerate up titration of the doses of the 4 pillars. And if they have persistent symptoms or intolerance to those drugs, then Digitalis may play a role. because unlike those drugs, Digitalis does not drop the blood pressure and may be better tolerated in patients with advanced heart failure and low or borderline low blood pressure. Also, Digitalis has a role in AFib with heart failure, and that AFib cannot be rhythm controlled. Evidently, when you have AFib with heart failure, the primary and by far the most beneficial therapy is rhythm control, specifically with AFib ablation. But some patients fail or are not candidate for that. And it's good to know that Digitalis can be useful in those patients. Now, this trial used digitoxin, which is slightly different from digoxin. Digitoxin is predominantly eliminated by the liver, not the kidneys, over 50% liver elimination, so it's less affected by renal fluctuations. However, on the other hand, it has longer half-life than digoxin, so if you become toxic to it, that toxicity will last longer. But I think the key idea is not digitoxin versus digoxin, is the use of low dose, and in that trial, they checked levels systematically at 6 weeks and they adjusted the dose based on the levels. And that's the key idea of Digit HF trial. And I want you to keep in mind this idea that when you have atrial fibrillation with heart failure and reduced EF, even beta blocker does not reduce mortality. Actually, this is based on a meta-analysis of beta blockers and heart failure with reduced EF. That landmark meta-analysis included great trials like CIBIS, MERIT HF, and Copernicus, and it showed that beta blocker evidently reduced mortality in heart failure and reduced EF and sinus rhythm, not in those with AFib. Absolutely no mortality benefit in those with AFib. And there was no significant heart failure hospitalization reduction in those with AFib. So interestingly, Digitalis is beneficial in patients with AFib and heart failure. Again, the primary therapy is AFib rhythm control, but if you cannot rhythm control them, you cannot do AFib ablation, it's good to know that we have a drug that can be beneficial in those patients. Even beta blocker was not. Now, I'm not telling you don't use beta blockers in AFib with heart failure and reduced EF. I definitely use it in conjunction with an attempt at rhythm control, but just keep in mind that limitation from that landmark meta-analysis. Another thing about beta blocker in AFib and heart failure, there is this very important trial called RATE AFib published in JAMA 2020 that is not much talked about. This RATE AFib trial took patients with AFib who were elderly, the average age was 75. They did not necessarily have heart failure, but half of them had heart failure and 20% had heart failure with reduced EF. And that trial compared monotherapy with digoxin versus bisoprolol. And interestingly, digoxin in AFib, many of whom had heart failure, improved functional class and NT-proBNP compared to bisoprolol, with a similar heart rate reduction compared to bisoprolol, and dramatically less adverse events and hospitalization compared to bisoprolol. So there is another piece of data telling us that digoxin is good in AFib, including AFib with heart failure. Again, the cumulative data is that Digitalis is not dead in AFib or in heart failure. Certainly in heart failure, it doesn't stand as tall as the four pillars, but it has a value in patients with advanced heart failure with refractory symptoms despite the four pillars or intolerance to the pillars or AFib. Another idea regarding patients in HFrEF with sinus rhythm, we do know that in compensated HFrEF who are in sinus rhythm, a heart rate less than 70 beats per minute is associated with better outcomes. This is partly because it reflects better, more compensated heart failure, but also probably because a sinus rate less than 70 may slow the progression of the metabolically depleted systolic heart failure. This is not the case in heart failure with preserved EF, where we know that actually higher baseline resting heart rate are associated with better quality of life and functional capacity. Now, where does Digitalis enter into this? We know that Digitalis reduces the sinus node rate, and Digit HF recruited patients up to a heart rate of 60 beats per minute, and the mean heart rate was 74 plus or minus 12 beats per minute. And in Digit HF, digitoxin showed a particular benefit in patients whose heart rate was over 75 beats per minute or systolic blood pressure less than 120 millimeter of mercury. Therefore, we can use Digitalis to reduce the heart rate in heart failure with a sinus rate over 70-75 beats per minute. As we know, this improves outcomes beside the intrinsic property of Digitalis that may improve outcomes in heart failure. And rather than using ivabradin, which only has one trial supporting it and which only works on the sinus rate, we can use Digitalis in patients with HFrEF and a heart rate over 60 to 70 beats per minute, as in the Digit HF trial. In fact, ivabradin reduces the sinus rate and may improve outcomes in HFrEF, but this comes at the cost of increasing the probability of developing AFib in heart failure. And I think the current class 2B digoxin recommendation in the heart failure guidelines is unfair, especially that those guidelines give a class 2A for ivabradin in heart failure with reduced EF. So I'll move on to another trial, which is the AQUATIC trial. But before I describe it, let me give you a background. The question is, if you need anticoagulation, typically atrial fibrillation, and you've undergone PCI or you've had an MI, you receive anticoagulation plus one antiplatelet the first year. Now, what will happen beyond the first year? Should you be on a single anticoagulant or continue anticoagulant plus one antiplatelet? We know from the AFIRE trial published in 2019 that single therapy with an anticoagulant without aspirin nor clopidogrel is actually enough. And in AFIRE trial that used rivaroxaban, standalone rivaroxaban beyond 1 year reduced mortality, bleeding, and cardiovascular events compared to rivaroxaban plus single antiplatelet. There was a mortality difference. We have another trial, EPIC-CAD with edoxaban. And in that trial, standalone edoxaban compared to edoxaban plus antiplatelet beyond 1 year of PCI or MI, we had much less bleeding with edoxaban and similar mortality and MI. So both those trials favor beyond 1 year of PCI or MI, only anticoagulation if you have an indication for anticoagulation, and do not give antiplatelet on top of it. But those trials took relatively lower risk CAD. In AFIRE, only 70% had prior PCI and 34% had prior MI. In EPIC-CAD, 34% had prior revascularization. So there was still some trepidation among some of us about the need for antiplatelet on top of anticoagulant if you've done complex PCI, especially complex PCI for ACS or left main PCI, multi-vessel PCI. So here comes the AQUATIC trial. Again, in patients who have an indication for anticoagulation, most of whom were AFib, but some of them were PE, even a very small proportion, 1% were mechanical valves. So they took those patients who need anticoagulation and all of whom had undergone a PCI with complex features more than 6 months ago, not even necessarily 12 months, more than 6 months ago. It had to be PCI for MI, 74% was MI, or for complex CAD, such as long diffuse disease or 3-vessel PCI or left main PCI, CTO, bifurcation, 2-stent techniques. So they took those patients and they showed that there was a dramatic mortality reduction with single anticoagulant versus anticoagulant plus aspirin. Dramatic mortality reduction. Look at this, 8.4% versus 13.4% at 1.7 years. And a dramatic more than 3-fold reduction of major bleeding. The most common anticoagulant used in this trial was apixaban, but they included all anticoagulant, even a small proportion of warfarin. Importantly, the median time since last PCI was 3 years and the interquartile range was 1 to 6 years, but 28% had PCI less than a year in that 6 to 12 month period. And here are the complex features of that PCI. It had to be for MI or for other complex anatomical features. And this is the major bleeding reduction, 10.2 versus 3.4% in such a short time frame. And the benefit, it tended to be identical in most groups. That includes groups with PCI in the last 6 to 12 months. So really, with all those data we have right now, if a patient needs anticoagulation beyond 1 year of a PCI, even complex PCI for MI, we should not be giving more than a single anticoagulant. There may be some exceptions. Maybe a patient with multiple prior MIs and multiple prior stent thrombosis with multiple complex interventions. But look, going forward, if I find that I'm adding antiplatelet to more than 10% of my PCI patients beyond a year with anticoagulation, I'm probably doing something wrong. It should be a minority of patients with that combination beyond a year of PCI. I will move on to another interesting trial regarding the duration of anticoagulation in patients with provoked PE-DVT. That's another practice-changing trial. I'll give you here some background. The traditional teaching and traditional data is that the yearly risk of recurrence after provoked PE-DVT is less than 3%, particularly if that PE-DVT has been provoked by a major risk factor. Major risk factor means a trauma with a fractures or major surgery or major hospitalization for more than 3 days. And it's about 3% after a minor risk factor, such as prolonged immobility or long airplane travel or a medical illness that is less than 3 days. Okay? So the recommendation has been that with provoked DVT, we give anticoagulation for 3 months. And maybe if it is provoked by a minor risk factor, the ESC suggests continuing anticoagulation long-term beyond 3 months. Now here comes the HiPro trial for provoked PE-DVT. This trial randomized patients with PE or DVT provoked by a major or minor factor, but in addition to that provocation, those patients had enduring risk factors for recurrences. So they randomized them after 3 months of initial therapy to extended low-dose apixaban, 2.5 milligram BID versus placebo. And they demonstrated that the risk of PE-DVT recurrence was indeed very high in those patients. Even though their PE-DVT was provoked, the fact that they had enduring risk factor caused the PE-DVT recurrence to be 10% at 1 year, and this was reduced dramatically to 1.3% with apixaban. And regarding those patients recruited, their PE-DVT was mostly provoked by surgery or trauma, meaning frequently major risk factor, not a minor provocation, and sometimes acute medical illness or immobility being a minor provocation risk factor. The enduring risk factors that those patients had beyond the provoked factor was mostly, very importantly, obesity, BMI more than 30, or chronic lung disease, or chronic inflammatory disease such as autoimmune disease, or chronic infectious states, or immobility, that was also very common, or they considered atherosclerotic cardiovascular disease, whether CAD or PAD, and heart failure, evidently. And the risk of recurrence at 1 year was 10%. That's at the upper end of what we know is the risk of recurrence in a patient with unprovoked DVT-PE. The range in unprovoked DVT-PE is 3 to 10% risk of recurrence at 1 year. So those patients had the upper end of that risk. Actually, their risk was as high or higher than most high-risk thrombophilia, except antiphospholipid syndrome, and cancer. In those thrombophilia, the risk is usually close to 8% and over 8% with the antiphospholipid syndrome and, of course, in cancer. So going forward in a patient with provoked PE DVT, don't just simply stop the anticoagulant at 3 months. Assess whether he has enduring risk factor, particularly obesity, chronic lung disease, chronic heart failure, chronic cardiac condition, inflammatory, infectious condition, immobility, those obese, immobile patients. So assess for that, and I would continue going forward apixaban 2.5 milligram BID. And even before this trial, I used to use those enduring risk factors in patients with unprovoked DVT-PE to confirm that they need long-term, possibly lifelong anticoagulant therapy. For example, I have somebody with unprovoked PE DVT and they are discussing with me potential discontinuation of anticoagulation. If the patient is morbidly obese and immobile, or elderly and immobile, or immobile with a degree of heart failure and preserved EF, I know this patient has a high risk of PE DVT recurrence regardless of those testable risk factors. So I don't waste time and money testing those patients for thrombophilia. What for? It's a waste of time and money. They have a high risk of recurrence. Your question is already answered without lab work. So be mindful and don't always follow algorithms. Another trial is regarding Mavacamtem in non-obstructive hypertrophic cardiomyopathy, but I will start by giving you a background. Mavacamtem is a myosin inhibitor that has led to dramatic improvements of symptoms and LVOT gradient in obstructive HCM. It reduced gradient by more than 60%, whether resting or post-exertional gradient, and 81% had complete SAM resolution. It completely changed the landscape of obstructive HCM therapy. In fact, it's so efficacious that it frequently obviates the need for septal reduction therapy in symptomatic patients who previously required it, who previously had refractory class 3-4 symptoms. And in the VALOR HCM landmark trial of severely symptomatic patients who were eligible for septal reduction, 82% of them no longer required the surgery or procedure 4 months after Mavacamtem treatment. And it's given a class 1 ACC recommendation for HOCM patients with persistent symptoms despite beta blockade. Now, Mavacamtem is fairly safe, doesn't have significant pro-arrhythmic side effect, but it has this one important side effect. Being a myosin inhibitor and a negative inotrope, it inherently reduces EF by a mean of 4%, and the only hazard is excessive EF reduction to less than 50%, which occurs in about 5 to 10% of patients in those landmark trials, and importantly, it reverses in nearly all of them with temporary 2 to 4 week interruption. Now, how about the use of Mavacamtem in that very difficult population of non-obstructive, restrictive HCM? There is really no one therapy that helps those patients. There is no data for beta blocker or calcium channel blocker in non-obstructive, restrictive HCM. It's a form of restrictive cardiomyopathy. We call it HCM with restrictive phenotype. Very few treatments for those patients. So here comes the ODYSSEY HCM trial from the ESC 2025. This trial specifically took patients with non-obstructive HCM, and very unfortunately, Mavacamtem did not improve symptoms or peak O2 consumption, although it dramatically reduced NT-proBNP in those patients with restrictive phenotype by 60% and troponin by 51% and improved diastolic echo parameter. So how to explain this disaccord between those findings? And I think the explanation is via EF reduction. In that trial, EF declined to less than 50% in about 20% of patients, much more than in the obstructive HCM trials. And this could explain the lack of improvement of the primary endpoint despite an improvement in diastology. Now, I've read some discussions of that trial, and some have considered Mavacamtem dead for non-obstructive HCM. I'm not that pessimistic. I would say that yes, currently I would not use Mavacamtem in non-obstructive HCM. However, there is some hope. I think potentially with less aggressive titration of the dose of Mavacamtem, maybe we can derive the benefit without the harm, and potentially aficamten may be beneficial. Aficamten is another cardiac myosin inhibitor that is shorter acting than Mavacamtem. It has a half-life of 3 days versus 8 days with Mavacamtem. That shorter half-life allows a quicker uptitration, but also quicker washout of the effect in case of an adverse effect such as EF reduction. And aficamten has been associated with less EF reduction. So myosin inhibitors are not necessarily dead in non-obstructive HCM. I think more trials are needed. And I want to comment on one last thing, which is the ESC 2025 lipid guidelines. It is mind-boggling for me that even in some primary prevention patients that they call very high risk, such as primary prevention patients whose 10-year risk is over 20%, or meaning a yearly risk of 2% or more, they recommend an LDL of less than 55 milligram per deciliter. There is no data based on my review of the literature regarding that aggressive reduction of LDL pharmacologically in primary prevention. The only trials that suggested that such aggressive reduction of LDL is beneficial were secondary prevention trials, particularly secondary prevention after MI, not any secondary prevention, such as IMPROVE-IT trial with ezetimibe, or the ODYSSEY outcomes trial, or the Fourier trial with the PCSK9 inhibitors. Those are the trials that showed that reducing LDL that aggressively by using those non-statin drugs on top of maximally tolerated statin led to improvement of outcomes, not mortality, by the way, but improvement in combined outcomes, particularly recurrent MI. So to apply this to a primary prevention population makes no sense. Even the less than 70 milligram per deciliter, which they recommend in patients whose 10-year risk score is between 10 to 20%, does not make sense either. Because again, even less than 70, I see no data supporting that in primary prevention. And I do agree that in primary prevention, high-risk population, such as those with a risk over 7.5% or particularly over 20%, there is a justification to give statin and reduce LDL, probably to less than 100. But to actively chase LDL numbers and add therapies in primary prevention seems unjustified based on data.